Welcome to Editor's Choice, the podcast at EuroIntervention, where we highlight the latest science and research in interventional cardiology. I'm your host, Aaysha Cader, and through conversations with the authors, we explore study design, key findings, and their relevance in contemporary practice. In this episode, we will discuss the 12-month results of the SAFE PROTECT randomized trial, which is left atrial appendage closure with the AnchorMan or Watchman devices. I'm joined by the senior author of this paper, Professor Huimin Chu, from the First Affiliated Hospital of Ningbo University in China. Welcome, Professor Chu.
Thank you.
The SAFE PROTECT trial compared the Watchman 2.5 device with the novel AnchorMan device for safety and efficacy in patients with non-valvular AF at high risk of ischemic stroke. Tell us a bit more about the background and rationale for this trial.
AFib is the most prevalent cardiac arrhythmia and associated with high stroke risk. Long-term LAAC is the first-line stroke prevention for non-valvular AFib. Yet, many patients suffer breathing complications, LAAC intolerance, and contraindication, or recurrent stroke despite therapeutic anticoagulation. Percutaneous left atrial appendage closure is established non-pharmacological alternative to LAAC for high stroke risk AFib patients. Watchman 2.5 is the most widely adopted left atrial appendage closure device globally with the robust randomized trial evidence, but it has limitations. Variable conformability to diverse left atrial appendage anatomies, frequent moderate peridevice leak, and risk of device-related thrombus, DRT, or pericardial effusion. AnchorMan is a novel Chinese-designed left atrial appendage closure occluder engineered to improve deliverability, anatomical fit, sealing performance, and procedural safety. SAFE PROTECT trial was designed as a prospective, multi-center, open-label, randomized non-inferior pivotal trial to head-to-head compare safety and efficacy of AnchorMan versus Watchman 2.5 in Chinese high-risk non-valvular AFib patients.
In terms of the device, how is the AnchorMan device different from the Watchman 2.5?
The distal end of AnchorMan left atrial appendage occluder is 3D folding, round while the end of Watchman device is sharp. This will improve the safety when advanced and retreats within the left atrial appendage. The threaded insert of the AnchorMan device is inlaid and the Watchman device is protruding. This may decrease the possibility of the DRT. The AnchorMan device is a semi-closed cage to conform better to anatomy of left atrial appendage and further improving the sealing performance.
Tell us a bit more about the inclusion and exclusion criteria for patients enrolled in this trial, including your specific imaging exclusion criteria.
The inclusion criteria included the first greater than or equal to 18 and less than 80 years of age with non-valvular AFib. The second, high risk of stroke and with transvascular score greater than or equal to 2 points for men and greater than or equal to 3 points for women. Patient had to meet any one of the following criteria: a documented history of hemorrhage or bleeding tendency. B, intolerance or unwillingness to use long-term LAAC therapy. C, stroke and embolic events while on standard LAAC therapy. D, hybrid score greater than or equal to 3 points. The exclusion criteria included the first, valvular heart disease, The second indication for lifelong OAC unrelated to AFib. 3. New onset, untreated, and secondary reversible AFib. 4. Ischemic stroke, TIA with 30 days, MI with 3 months. 5. PRASD, PFO closure surgery, device implantation, systemic cardiac disease. 6. NYHA class 4 heart failure, severe renal dysfunction, pregnancy, breastfeeding, and planted pregnancy with 1 year, life expectancy less than 12 months. As for the imaging-based exclusion criteria, including left atrial appendage maximal orifice diameter less than 17 millimeter or greater than or equal to 31 millimeter, left atrial diameter greater than or equal to 65 millimeter, LVEF less than 30%, intracardial thrombus, high-risk PFO, and significant pericardial effusion, depth greater than or equal to 4 millimeter.
Let's talk a bit more about the trial design. This was a non-inferiority trial. How did you define the non-inferiority margins, and what were the powered endpoints that you looked at?
The non-inferiority margin was calculated using the historical benefit observed for the composite efficacy endpoint of the Watchman device in published pivotal trial, just like Protect AF trial, ASAP trial, and Prevail trial, with the better trial difference, defining the maximum historic variability considered clinically acceptable for the device, rounded conservatively to 7%. The primary endpoint was clinical success at 12 months, defined as freedom from ischemic stroke, hemorrhage stroke, systemic embolism, cardiovascular death, or death of unknown cause. As the secondary endpoint was left atrial appendage closure success in 12 months, defined as successful left atrial appendage closure by TE documented absence of PDL or PDL less than 5 minutes.
And once patients were enrolled, walk us through the procedural aspects very briefly, and also follow-up imaging and antithrombotic treatments that you applied.
The implantation technique for both AnchorMan and Watchman was similar. Briefly, the size of occluder was selected based on the procedure TE measurements and intra-procedure LAA angiography results. The device was advanced into the left atrial appendage through the delivery sheath and deployed by retracting the sheath. After implantation of the occluder, the pass criteria used for the Watchman device release. For the AnchorMan device, the 4S criteria was used to evaluate whether the device was suitable for release. TE assessment was required at 2 months and at 1 year after the procedure. The recommended drug-treat regimen was OAC plus SAPT for the first 2 months, followed by DAPT between 2 months and 6 months, and SAPT thereafter.
And tell us about the results now. What were the main demographic and procedural characteristics, and also the main endpoint results?
Baseline characteristics was well matched between groups. Approximately 60% of patients were male and with high mean transvascular score of 4 and 3.8 respectively. Over 67% of patients were intolerant to or refused OAC therapy. Most patients had local anesthesia. Procedure time and X-ray exposure dose were comparable between groups. The occluder was successfully implanted in all cases. The rate of PDL by ETE after occluder implant was numerically higher in the Watchman group, but was not significantly. No PDL greater than or equal to 5 mm was detected in either group. The complications were comparable between groups. As for the endpoint, the primary clinical successful endpoint was 98.1% in both groups, meet the primary endpoint of our study. In addition, the AnchorMan was non-inferior to Watchman for the powered secondary efficacy endpoint of left atrial appendage occlusion.
Peridevice leak is an important assessment following successful LAAO closure. And in this study, the rate of PDL greater than 3 mm was significantly lower in the AnchorMan group. Given these results, what are the design aspects that provide an advantage for AnchorMan over the Watchman devices, and how might these have contributed to better outcomes?
The rate of PDL was numerically higher in Watchman group, but was not significant. However, PDL greater than or equal to 3 mm was significantly lower in the AnchorMan group compared to the Watchman group. AnchorMan device is a semi-closed cage design and consists of a dense native frame with 12 tool struts, conforms better to the shape the left atrial appendage ostium. It may be improving the sealing performance.
And in terms of some of the limitations that you've listed, the trial, of course, was conducted only in mainland China and compared the AnchorMan device against the Watchman 2.5 and not the more contemporary Watchman FLX Pro device. So, as a final takeaway, what other research are on the frontiers in this space?
As for the AnchorMan device, we will perform several research to further investigate the safety and efficacy in clinical setting, such as AnchorMan long-term 5-year follow-up, head-to-head trial versus Watchman Flex Pro, real-world registry study across device population, and combined left atrial appendage plus ablation optimization research.
Thank you very much, Professor Chu, for being on this podcast and discussing your paper.
Thank you very much.
Thank you for listening to Editor's Choice. To read the full article discussed in this episode, visit EuroIntervention.org. And if you've enjoyed this podcast, please subscribe to Editor's Choice for more conversations behind the science published in EuroIntervention.